Good morning, chairpersons, ladies and gentlemen. Thank you, Dr. Priyankara, for that words of introduction. First of all, let me thank the new Society of Internal Medicine, the President, Dr. Senaka Rajapaksa, and the Council for inviting me to deliver this presentation on prescribing in pregnancy. We cannot talk of prescribing in pregnancy without speaking about thalidomide. We changed the history of pharmacovigilance about 50 years ago. In 2016, the world commemorated this disaster, and Daily Telegraph said justice has never been done and it burns away. The thalidomide disaster people are still trying to resolve this puzzle. Distaval, which was promoted as a safe sedative and method for sound asleep, resulted in these gross teratogenic effects in babies, and it took about few years for people to recognize and point this to the sedative that was given in pregnancy. So this disaster changed the laws pertaining to teratogenic testing of new medicines. Before this disaster, teratogenic testing was not made mandatory, but after that it was made mandatory. And in fact, the yellow card system in the United Kingdom of spontaneous reporting came into being after this thalidomide disaster. It also changed the attitude towards medication taken during pregnancy, where there was a resistance to take drugs by women, as well as some resistance to prescribe the drugs by the doctors as well. What are the problems that we have in prescribing in pregnancy? We have to balance the benefit versus risks as we do in all other situations. However, this evidence that we talk about is quite limited in pregnancy, because, as you know, there are very few clinical trials that are conducted among pregnant women, and therefore we make the therapeutic decisions based on the weakest level of evidence, coming mostly from case reports or from case series or retrospective studies particularly. If you talk about the magnitude of the problem, 1/3 of children born in the UK are due to unplanned pregnancies. And the potential teratogenicity needs therefore considering whenever we prescribe for a woman of childbearing age. And the studies have shown that about 50% of pregnant women will take a drug at some point in their pregnancy. So therefore, talking about prescribing in pregnancy and the issues involved is quite relevant. When you look at the published studies on prescription drug use in pregnancy, this study coming from the US looked at the drug exposures, particularly the drugs categorized according to the older system, categorized under category D or X, and it showed that about over 3,000 patients have been prescribed in pregnancy, mostly in the first trimester, these drugs. Talking about this previous US FDA classification, category D are the ones where there is positive evidence of fetal risk, but the benefits may be acceptable. Good examples are the anti-epileptics. And then category X are the ones where there is definite risk, and risk clearly outweighs the possible benefits. Good example is thalidomide. So when looking at the most common US FDA category D and X, you can see the number of instances where it was where these category X drugs were prescribed. Particularly of note, drugs like statins, simvastatin, even warfarin, and other statins have been prescribed. Exact numbers of women, like 280,000 women in USA alone, according to this study, out of 4 million pregnancies were exposed to these drugs in pregnancy. Right. Talking about teratogenic risk, it is determined, as you know, by the time of exposure, and the greatest risk is from the 3 to 8 weeks of conception. And teratogens are classified as substances which cause congenital abnormalities or abortions or other structural defects. We know that teratogens act with specificity, and they demonstrate a dose-response relationship. And sometimes genotype of the mother as well as the fetus can affect the susceptibility, and the effects depend on the timing of exposure, which is shown in this dysmorphogenic calendar. It is fortunate that in the first period, which we refer to as pre-embryonic phase, lasting about 0 to 17 days post-conception, we have all or none law, because the pluripotent cells can either fully correct the abnormality or it will result in a miscarriage. And the critical period is this teratogenic period, where it is 3 to 8 weeks of post-conception, where we get all the severe teratogenic abnormalities. And in the fetal phase, which is after the 9 week of post-conception to birth, we get fetal growth affected. So this slide shows this period. So as you can see, the first, okay, it's all right. You can see that the first 2 weeks results in prenatal death, that is the all or none law period, and then the 3 to 8 week period is the typical period of teratogenicity, and subsequently it is the postnatal period. Following that, you get, okay, yeah, that's it. Following that, you get the period of fetal development, where still some of the drugs can result in effects on the fetus. So the major malformation risk in general population is about 2%, and some of the medical conditions may increase that risk, for example, even in patients with epilepsy. And drugs associated with an increased risk do not affect the majority of the exposed fetuses, well shown by anticonvulsants, where about 90% of the patients do not develop any major structural abnormalities. However, and teratogenic effects that are shown in animals may not be shown in the humans. A good example again is corticosteroids, and we know that the teratogens must reach the conceptus through the placental barrier to give the effects. So the placental barrier, like the brain, protects the fetus from the environment, and so therefore a barrier similar to the blood-brain barrier is located in the placenta, which separates blood from the mother of the fetus. And the lipid-soluble drugs are the ones which can readily diffuse this barrier, where within 5 minutes of taking the drug, some of these drugs can reach about 75 to 100% of the concentration that you see in the mother. Another problem in the when the drug reaches is the fetus lacks the barrier that the mother has against drug reaching the brain. So therefore, fetus lacks the protection that the mother possesses, because the fetal blood-brain barrier is less developed. So that is why now there are several studies which are showing that there are effects on the brain of the baby if when exposed to the drugs in the fetus. And when we talk of effects of pregnancy on the drugs, we know that the pharmacokinetics are affected because of increased blood volume, reduction of the increase of the plasma protein levels. So therefore, and also there is reduced absorption and increased elimination of most of the medicines, which leads to reduced total plasma drug concentration, and the free drug to protein binding also may be altered. So therefore, changes in the dose should be guided by the free levels of the drug or the clinical need. And we know that in countries like Sri Lanka, when we try to prescribe, most of the time, we cannot get a drug level of the important drugs, so that also hinders prescribing. Increased renal clearance can increase the requirement of the drug. A good example is insulin, where the dose needs to be sometimes increased during pregnancy. Drugs like lamotrigine, where clearance increases from first trimester to the third trimester up to about 300%, and then clearance decreases from about 32 weeks and returns to baseline within 2 weeks of delivery. So therefore, there are changes during the period of pregnancy and immediately afterwards as well, and these changes vary between individuals. So that is why monitoring of levels and the symptoms before and during pregnancy is required. Right, when we consider prescribing in pregnancy, we need to consider 3 scenarios. Firstly, prescribing for a woman of childbearing age group. Secondly, for women and as well as men who are having chronic illnesses, pre-pregnancy counseling. And then thirdly, principles during pregnancy, early pregnancy, as well as after the first trimester. Let me focus on these three situations now. So, considering prescribing for women of childbearing age group, I think the most important principle is we have to consider every woman of childbearing age group potentially becoming pregnant. That is the only way of preventing unnecessary and avoidable effects on the fetus. So, contraception while on teratogenic drugs is very important, and some drugs can reduce the efficacy of contraceptives like rifampicin, so those have to be taken into consideration. And we have to always inform the possible adverse effects on the fetus or the newborn of untreated illnesses. We need to review the drugs with very long half-lives that have an influence even long after stopping. Good examples are drugs such as amiodarone as well as leflunomide, where you can have effects even up to 2 years since stopping the drug is there in the body. Right, so pre-pregnancy counseling is vital for patients who have chronic disorders, where women with chronic medical conditions are now frequently becoming pregnant. So, in these patients, pregnancy should be well planned. We need to review the key medicines which are known to cause teratogenicity or fetotoxicity and modify the medicines accordingly. And we have to ensure that the patient embarks on a pregnancy when the disease is well controlled and well supported by specialists throughout the pregnancy. So, I would like to give you some of the findings that we published last year on pregnancy outcomes and contraceptive use in patients with SLE, rheumatoid arthritis compared to patients with chronic disorders. And what we saw was most pregnancies were unplanned. You can see in this slide, we looked at the outcomes, and almost all the outcomes that we looked at, the live births, the term deliveries, normal vaginal deliveries, normal birth weight, and yes, disease flares during pregnancy, all were much higher in patients who had an unplanned pregnancy compared to those who had a planned pregnancy. We should not forget men in this exercise because they are also equally responsible for the conception. And for example, in many thalidomide-associated embryopathy occurred in children of men who use the drug. So therefore, using teratogenic substances in men is also equally important. And nowadays, isotretinoin used for in severe acne is the most teratogenic drug since thalidomide, and it is used in men who might give, result in a pregnancy and may have effects. So, and also we use methotrexate in patients who have inflammatory bowel diseases, and that can result in effects on the fetus. So therefore, these things have to be considered when prescribing for men who are having chronic disorders. Right, so what are the general principles for early pregnancy? We need to take a full medication history, including the prescribed drugs, over-the-counter medications, as well as illicit drug use. Fortunately, it is not that much of a big problem like in the West, but we are seeing it more and more in this country. I think we had some presentations at the last month's Ceylon College of Physicians where party drugs were discussed, and it was highlighted that now that is becoming a problem in Sri Lanka as well. And we had to calculate the gestation using the LRMP, and we need to stop sudden stopping or changing the drug to reduce the risk of major malformations, because once the patient has become pregnant, stopping is generally will not do anything much, because the patient the fetus has already been exposed, because patient is at least 6 weeks pregnant by that time. So general advice is not to stop essential safer medicines, but we need to seek specialist advice when unsure. So the general principles are you have to use the lowest effective dose and avoid polypharmacy because that adds to the risk. And as a principle, we should not use any of the new drugs, the new chemical entities, because we get the information on the effects only after people have been exposed to the drug, and we don't have that information with the newer chemicals that are approved. Chemicals or the biologicals for that matter now in the current situation. And it is always safe to choose a drug which has been in use for a long period of time. For example, tricyclic antidepressants are preferred over SSRIs in depression, because SSRIs, there are a lot of new data coming on the effects on the fetus. We have to balance the risks of potential adverse effects, particularly on the fetus, with the benefits that will be given to the mother in treating the disease. And we have to appreciate that this balance may change during the pregnancy. For example, for a woman with inflammatory bowel disease, biological therapy in the first trimester may be acceptable because they do not cross the placenta until the second trimester, but in the third trimester it may be reasonable to use a high dose of steroids. And in balancing risk versus benefits, we have to consider very carefully. For example, asthma, benefits outweigh the risk, as well as in epilepsy, but we all know that in acne, risks outweigh the benefits. Right, so after that period, the fetotoxic period, it can occur anytime between late first trimester and the birth, which can cause a variety of effects. And effects of the drugs on cognitive function are now coming up, particularly with brain development, because brain development occurs right up to the time of birth and even beyond. So therefore, these effects can be manifested. So that's why I said SSRIs, now there are several concerns. And these are some of the drugs affecting fetal growth. ACE inhibitors can cause renal failure, NSAIDs, renal dysfunction, and premature closure of ductus. Warfarin, we know, can bleed into the brain and cause microcephaly. Tetracyclines, the dental effects, and benzodiazepines, the dependence in fetus. So general principles is to avoid, if possible, reduce the dose near delivery, and reduce the risk of withdrawal in the neonates. However, the risk of maternal relapse may have to be taken, may be more detrimental to the newborn. For example, suicide is an important cause of maternal death, and psychiatric illness is a bigger risk factor, so they need to be adequately controlled. And if you need SSRI, fluoxetine seems to be preferable. And we need to keep ourselves updated as the new data emerge, especially for commonly prescribed as well as the relatively new drugs. A good example is valproate, because early this year, UK had several publications, and they banned valproate without the pregnancy prevention program in place. Because valproate has been shown to, in addition to the well-known malformations, there were several effects on the fetal brain development. There have been developmental problems in about 3 to 4 children in every 10, and the long-term effects are still unknown. So 3 to 4 babies of every 10 exposed is quite a high risk, and they are late in walking, and they have lower intelligence, memory problems, ADHD, and so on. This study that we published early this year, we looked at the obstetric outcomes in women with epilepsy, and we saw that valproate was used in the first trimester in about over 25% of patients. And that this slide shows that this is the first trimester valproate use, and they were changed to very often carbamazepine by the second and third trimester. So this indicates that it could have been possible to change these drugs before the patient became pregnant. So these are the things that we need to focus our attention in Sri Lanka. There are so many, several drugs which have good safety record in pregnancy. I don't want to go through the details in the interest of time, but we must select some of these. And these are the studies that have been done on safety profile on medication use in pregnancy. So the possible safe medicines and risky medicines have been identified. And the most common drugs that were dispensed are given here in that particular study. And you can see drugs like ibuprofen, the combination analgesics, metoclopramide have been used where others can be used. So now there are several guidelines, for example, British Rheumatology Association guidelines on, for example, in rheumatological disorders. Several guidelines are coming up on prescribing in pregnancy, so those have to be consulted when prescribing. Steroids, so prednisolone is compatible in each trimester with level 1 evidence. Azathioprine, which we earlier thought should not be given in breastfeeding, now is allowed in breastfeeding as well as in pregnancy. So the need for treating maternal illnesses is also very important because all these conditions have to be well controlled, like diabetes, SLE, antiphospholipid, and we must also address the contributing and confounding factors to treat the underlying illness. There are some drugs beneficial to the baby, for example, thyroxine. It improves, the brain function. So majority of circulating free thyroid hormones are particularly maternally derived, so we have to inform that to the mother as well, otherwise they might not take it during pregnancy. Recently in 2014, there was a new pregnancy and lactation labeling rule in the US FDA because earlier categorization of 5 categories A to D and X was thought to be too simplistic, and therefore this one came in where pregnancy, lactation, and effects on male and female reproductive potential also taken into consideration. So this labeling rule now requires to give more information in the product information leaflet, which will be more useful for the prescribers. So if you want to find information, first line sources would be, we look at the BNA for other online sources. Second line would be the product information leaflet and published articles. There are these Briggs is a good, continuously updated. You can find information on prescribing in pregnancy and lactation. And finally, there are these online resources. Unfortunately, they are not available free. We have to pay to get information. So that's a problem that we have in these countries. So finally, ladies and gentlemen, medications in pregnancy is a tricky business, but we need to make it safer for the mother and the baby, keeping thalidomide disaster in mind. Thank you very much.